lot of clinicians that I work with, they're residents and they mostly see adults. When they come into the pediatric ER where I work, they get very intimidated by pediatric films. So I'm really glad today to have Shawn Sato here, who is a board certified radiologist, but not just regular radiology. He is also pediatric board certified. And we're going to talk about some big differences in pediatric bones compared with the adults. So Shawn, let's take it away.
Sounds good. Thank you very much. So today we're going to be talking a little bit about pediatric musculoskeletal films. We're going to be kind of reviewing some of the basic anatomy of pediatric bones compared to adults, and we're going to kind of try and gain some comfort reading pediatric musculoskeletal films by looking at some common cases that you're going to see in kind of the primary urgent care setting. So one of the main topics that I think always scares people when it comes to pediatric plain film imaging is what makes pediatric bones different from adult bones. These are not just little adults, as they say. So pediatric bones have a higher fluid content than mature adult bones, which means that they're going to break a little bit differently than you see in adult patients. So because of this fluid content, these bones tend to kind of bend rather than snap. And so when I think about this, I try and think of like a straw that you bend, and you kind of get that crease in it when you bend it too far. And that's kind of what you get with these pediatric patients, where you get these buccal fractures, and you might get a fracture of the bone without actually breaking through the cortex. As that bone matures a little bit and gets a little less fluid in it, you can get something called a green stick fracture, where you get cortical breakthrough on one side, but the other side you're just kind of getting that bend. With these kind of fractures, since you're not getting the actual break of the cortex, they can usually heal a lot faster and usually don't require quite as much management as they do if they're broken into a million pieces, like what would happen if I broke my wrist at this age.
Now, they sometimes even bow and just bend. I find those extremely challenging because I don't know if it's just like a crooked bone that's normal or if it's an actual like bowing deformity.
Yeah, absolutely. It can always be kind of challenging. And so hopefully that by going over some of this stuff, we can kind of get a better idea and kind of recognize when we see some of these cases. Another thing about kids is they heal really, really fast. They're kind of like Wolverine in that if you put the bones in the same room, they're going to heal incredibly quickly. This is an example of a patient that had a humerus fracture due to birth trauma. And you can see that by day 7, there's already a huge bony callus. And 2 weeks in, a lot of remodeling, and that bone's already reapproximated. If you were going to see this in an adult patient, these timelines would be much, much further out. And I think that bone callus that you'd see at 7 days, you'd be lucky if you saw that at 2 months in some older patients. So one of the things that's always a hot topic in pediatric musculoskeletal imaging is ossification centers.
I know the term and I think I know what it means, but what exactly is an ossification center?
So an ossification center is kind of where the bone gets created. And so what happens is we talk about our primary ossification centers, which is kind of at the end of long bones. And this is where the bone proliferates, matures, and mineralizes, kind of starting out initially as kind of a cartilage and then kind of becoming the dense bone that we normally see. And that seems kind of like that can be a little bit of a foreign concept, but when you take a look at a pediatric plain film, the thing to remember is we'll take a look at a bone, and that space these are some images of a knee, that space between where the femur is and the tibia is, that's just not an open space. There's stuff there. And so that's the cartilage. And so when you have that cartilage, it kind of starts ossifying and getting that bone formation. And as you can see, as this patient gets older, we're going to get ossification of that epiphysis, which gets bigger and bigger and bigger and finally fuses. And the big thing to understand here is that cartilage is not going to be radiodense, so you're not going to see it on a plain film.
Right. I think the intern version of me thought that these could really slip around, but that dark space is actually solid cartilage there. It's just not dense enough to show up.
Yes, exactly. And I think that's an important thing to understand. And once you realize that, pediatric plain films get a little less scary because you don't think that they're just kind of like a Raggedy Ann doll with arms, legs kind of flopping all over the place. Here's another lateral view of that knee, and again, you can kind of see how initially at birth we're not really seeing the epiphyses, and then as you get older and older, kind of that rounded area around the knee, those epiphyses are kind of getting bigger and bigger, and eventually by 7 years, You can even see the patella, which we weren't even seeing before that.
Right, it looks like the patella just sort of magically appeared and didn't exist, but it existed just in cartilaginous form.
Yeah, exactly. That's exactly what we're talking about. So kind of getting an idea of what these ossification centers are and understanding where they exist is really helpful in understanding what's a fracture and what's not a fracture. Even as a pediatric radiologist, I don't know every single ossification center, but it's important to have good references that kind of help you identify where these are and kind of what normal bones look like at certain points.
So they have like predictable timing as to when they ossify?
They often have ranges, but just understanding that like this is a place where there is an ossification center. So if you see something funky there, you can kind of look at a reference and say, okay, so normal people have this, so this probably isn't a fracture.
Got it.
And two really good references. There's a book called Keats, which has a lot of normal variants that mimic disease. It's a big, thick book. It's awesome. It's one of the first radiology books that most radiologists get when they go finish their training, just because it's something that's really useful and easy to flip through. There's also an online website called Bone Pit, which is a really good reference. It just shows a lot of normal musculoskeletal plain films. It kind of just shows you things that you can normally see in normal patients.
That's really helpful if you're like on your own in the middle of nowhere. You can go to these sites and check them out.
Yeah, absolutely. I think it's super helpful, and it's one of those things that just knowing they're out there and knowing you can find them is something that's really useful. So this is a 12-year-old male with an inversion injury, and they have pain at the base of the 5th metatarsal. Do you see anything on this, Saul?
I mean, I see a little fleck hanging off the proximal 5th metatarsal, but I don't know if it's normal or not. But you said he's 12, but I don't know enough about my ossification centers to know whether that's normal or not. So I'm gonna call you.
Yeah, that's good. That's what I like. Keeps me employed. So what Saul's talking about is kind of shown with this arrow here, and I agree. We see that, and we're kind of trying to figure out if that's where he hurts, but is that something real or is that some normal variant? So when we take a look at it, we can look up a normal patient that's that age, and what do you see on this normal study?
I mean, it looks like the same thing, but sort of stuck closer to the bone to me.
Yeah, I agree. So we're seeing something that looks similar. It doesn't look exactly the same, but it looks similar. And so that's kind of that's an apophysis at the base of the 5th metatarsal, and we can see that normally. And the thing that you were asking is like, what ages do we see this and that? And I think it's really hard to know that for certain because some kids' bones mature kind of later, some earlier, and so to put a lot of faith in that, you kind of want to know a ballpark, but you give people some range and allow them to be a little ahead or below the curve. So like when I take a look at this apophysis looks a little more immature than the one in the normal, but I still think it looks like an apophysis to me.
Yeah. Now, I hear people talk about like, it's well corticated and adjectives like that. Like when I look at the one that's normal, I feel like that looks well corticated, like it's very smooth and nice. And the one on the left where there's an injury, is that well corticated or not? And how do you figure that part out?
So well corticated kind of means that the bone looks very contiguous. It doesn't look like there's any sharp angles on it. And I agree that the one that our patient, it doesn't quite look as mature. And so that's what I was saying, that I think that over time the foot will look more like the normal, but it's probably just a little bit slower than normal.
Right. Another scenario I often find is I'll get an x-ray because they have pain elsewhere, and then you'll see some of these ossification centers, and then we're all going, I got to go back and like touch the kid in that area. Yeah. And I find that to be very helpful if they're not tender at all and it looks nice and smooth and round, then I may be like, okay, maybe that's an ossification center, but I'm still going to call Dr. Sato.
That is super, super helpful. And when I was in training, one of the things that I got to do is I worked with a pediatric orthopedist, and it was one of the best training experiences for me because every single patient came in with an x-ray and he would say, do you think this is broken? And I'd say, well, there might be something here. And he goes, let's poke on him. And if that's where it hurts, it's a fracture. And if it doesn't hurt, that's not a fracture.
So clinical correlation is real?
Yeah, apparently.
Is that what you're saying?
Yeah, and I'm saying as a radiologist, I got to touch patients once and I got to actually do a clinical exam.
And you immediately ran back to the dark room.
Yeah, exactly. Okay, so one of the other things that we can do is take a look at the contralateral side. And so when we get a contralateral view on that same patient, what do you see here?
It looks kind of similar to me.
Yeah, exactly. And so disease rarely happens symmetrically bilaterally. And so if you take a look at one side and the other side kind of looks similar, it kind of gives you a little bit of comfort knowing that it's probably not abnormal. And so I think that this is a really nice example of how you can utilize kind of symmetry in the body to try and evaluate this. This being kids, I'm not always in love with getting the other side plain films just because I don't want to radiate them more. But if it's necessary, it's something that's easy to do. And plain films don't have a huge radiation dose. So if it's going to help the patient, I don't think there's any worries about doing that.
So if this kid is tender over that base of the fifth with this film on the left, would you call that as a fracture?
I wouldn't.
Okay.
If anything, I might call it like an apophysitis, but it doesn't look like a fracture to me.
Okay.
I don't see any broken bone.
I'd probably still splint him.
That's fine. What do you splint at the base of the fifth? Do you just put him in a boot or something?
Yeah, I'd put him in a boot.
Okay.
Yep.
That's reasonable. It's not going to hurt him.
And is there anything to the idea that if you're totally unsure and you do splint them, that you could send them back for repeat films to look for callus formation in a week and a half to 2 weeks?
Absolutely, absolutely. And we're going to talk about that a little bit later with another case, but that's something that we can definitely do. And I think it's really hard sometimes to say, I don't know the answer right now, but we'll give them a little bit of time. But that's a super useful skill in radiology. And if you can do that, that's something that, if you're not sure, absolutely.
Right. I tend to blame the pediatric bones themselves. Like, it just doesn't show up well because they are so much cartilage at this age. Let's put a splint on and we'll find out the answer. If the body decides to put more bone down, then it was probably a fracture.
Yeah, absolutely. I think that's a great idea. That's a really good strategy. Okay, so again, we talked about this quite a bit, but if there's an area of fracture and you're not sure if it's fracture ossification center, know that there's some references out there that you can look it up in or get the contralateral side if you need to.
Cool.